Melissa, can you start the recording? Perfect. All right. Hello, everybody. Good afternoon. Welcome to our third meeting of the cost growth target for 2026 to 2030 work group. Hopefully, everybody is in the meeting that you think you're in. This meeting is being recorded. This meeting is also being transcribed. Let's go to the next slide, please, Melissa. Closed captioning is available, and please stay muted until it's your time to speak. I think I'm expecting maybe a lot more discussion today, so let's try to use the hand raise function, and that'll sort people in order so we can call in people and just try to keep facilitation going. But welcome, everybody. I know that we sent materials out on Monday, so short notice, but materials coming rapidly between meetings when we're meeting this frequently. So let's look at the agenda for today. Next slide. We want to start today by summarizing the conversation so far and want to regroup a little bit on the intention and the charge of this body of work. I want to follow up on some of the homework and the OHA discussion since our last meeting. We're going to spend the bulk of today's meeting looking at economic data. We're specifically going to look at Oregon data today, or as close to Oregon data as we can get, and start discussing implications for potential targets. Want to also hold some time at the end to figure out the plan for meeting 4. This meeting is sort of the end of our very specific work plan where we were like, yep, we're going to set the stage, we're going to get the data in front of you, and then question marks. So I'd like to spend some time at the end of today to figure out what more or additional data do you as a work group feel like you would like to see in meeting 4? And what are the key questions that we want to be answering, and how do we want to structure the agenda for the 4th meeting? So that's our plan for today. Any questions about the agenda? Okay, next slide. This just reviews the work plan. I think everything I just said, where we're going to review the economic data today, and then meeting 4 and 5 in November, we will hopefully be developing a recommendation, but question marks. So next slide, just a reminder that we are not holding public comment periods during the meetings, but that anyone can submit public comment, a written comment about this process until November 30th. And public comment that we receive will be posted online and shared. So I wanted to flag that we've received 2 comment letters from workgroup members. They are both posted on the workgroup webpage. There's a letter from Providence Health Plan and a letter from the Hospital Association. And again, I apologize, totally my fault that I did not push both of those to the full workgroup on Monday. I dropped the ball on that. So wanted to make sure everyone heard that there are 2 comment letters and those are available on the website. And workgroup members, as you are emailing your own feedback or questions in, I would really appreciate if you intend them to be public comment versus just a suggestion for the agenda. Let me know if you intend your emails to be public comment. That will help us know what to post. Okay, are we ready to summarize the last couple meetings and regroup? Great. So let's go ahead 2 slides, please. So, reminder, the workgroup charge is to review the economic trend data and make a recommendation to the Oregon Health Authority about what the cost growth target should be set at for 2026 to 2030. OHA will make the final decision on what the cost growth target is for this time period, and OHA is planning to make that decision and issue the update by the end of December. Next slide. So far, in the first 2 meetings, we have reviewed a lot of content. So the charge, the processes, the cost growth target program, what cost growth trends in Oregon has looked like over the last couple of measurement periods. We've talked about how the initial committee set the target in 2020. We've talked about the cost growth targets in other states, what they're based on, what their values are, who sets them, how often they set them. We've heard from Connecticut about their process earlier this year to reset their target. And we did a high-level overview of potential economic indicators. These are the economic indicators that the initial committee looked at back in 2020, and we're using that as our starting place for this conversation. Next. At our last meeting, meeting 2, you all raised some really important questions that we needed to talk about and needed to maybe pause and regroup on before moving forward with the recommendation. And these questions, I'm going to paraphrase them as what is the goal of the cost growth target? And related, what message should it be sending? Is the purpose of the target to be aspirational or attainable? Should the work group assume that other aspects of the cost growth target program, such as performance improvement plans and financial penalties and reasonableness determinations, are fixed? That one we can answer. Yes, you should assume that. We are looking just at the target itself in isolation of those other program factors. And then what was the legislative intent? And is there anything that we can learn from the legislative intent or some of the initial conversations about how the target should be set and what the purpose, goal, and message should be? We asked everybody to look at the legislative intent and some of the statutory language as homework. And I want to start us off today with just regrouping on some of that and sharing how OHA interprets that. Next slide. So we went back to the Senate Bill 419 Joint Interim Task Force report. This is the report that made a recommendation that said Oregon should pursue a cost growth target model like Massachusetts. It should be a total cost of care approach. It should include all payers and providers. There should be a phased timeline. All of those recommendations that led to the establishing legislation. There is nothing in the task force report that we see that references whether the target should be attainable or aspirational. So no guidance coming out of that task force report. However, it is clear in that task force report that the intention is that the cost growth target should be annual. It should apply to all payers and providers. There should be accountability for cost growth that exceeds the target, and the target should be tied to an economic indicator. Next slide. Oh, go back. There we go. So we then looked at Senate Bill 889. This is the 2019 legislation that established the program. We looked at the legislative language itself as well as the whereas statements as part of that bill. And again, no mention of attainable versus aspirational. But again, we see those same intentions that were in the legislative task force report. It should be annual, it should apply to all payers and providers, and it should be tied to an economic indicator. Next slide. So one of the pieces of homework that I guess I assigned to ourselves at OHA was to go back and have a leadership conversation and make sure that we were able to provide some direction and some intention setting to you as the work group. So I wanted to share, we had those conversations and here's where we landed. So on the left side of this screen are three statements from the legislation. And on the right side is how OHA interprets those. So the first bullet point, healthcare spending should not outpace inflation and Oregon's economic growth. OHA interprets that as the target should be set in a way to bring healthcare spending in line with inflation and Oregon's economic growth. The second bullet is that the cost growth target should be set in such a way to reduce the total cost of healthcare. OHA interprets that as the target needs to be set sufficiently or in such a way that it will reduce the total cost of healthcare. If set too high, it may not have an impact on healthcare costs and will not help reduce the total cost of healthcare. And finally, the target should use established economic indicators. And OHA interprets that as the target needs to be grounded in data. I think grounded in versus pegged to is one of the questions that we've had. And that is a question we want to continue to discuss with you as the work group, but wanted to make sure that we do have that tie to an economic indicator in some capacity. Okay, I see hands. In order, Keaton, Sierra, and then James.
Uh, thanks, Sarah. I'm very curious about your interpretation of the word reduction here. Do you mean reduction in nominal dollars or real dollars, or what do you mean by reduce?
I think when we're talking about the cost growth target program and body of work, we're talking about reducing the rate of growth of total healthcare costs in the state.
Okay, that's important. Thanks.
Yeah, great clarification. Sierra?
Yeah, sorry. Thank you. I know that you provided the task force, which is not part of the enabling legislation, and then the whereas statements. And so coming back to this slide, can you just remind me the source for the very first statement that healthcare spending should not outpace inflation and Oregon's economic growth? Is that verbatim from anything?
Oh, great question. Can I get back to you on that? Because I don't want to tell you the wrong. I'm not looking at it, so let me get back to you.
Yeah, that would be helpful because I think something important too is we're thinking about the legislative intent and then the actual implementation of the program is that whereas clauses are not statute and do not have the weight of law, they're only used to the extent that the statute is ambiguous. But really, in this case, both the enabling legislation and whereas clauses are silent on how aggressive the target should be. And so
Sure.
I'm not sure that this is providing like
And yep.
right level of guidance about we're talking about reducing, like that is very clear, I
Let
think,
me
in the
let me
intent of
restate
the
this then.
statute. So the
Yep.
degree to which I think is still going to be a point of
Yep.
contention.
And that is totally fine for it to be a point of contention through this entire work group process. Um, I think the question that we left off the second meeting with was, is there any guidance in existence about whether or not the target should be aspirational or attainable? In my view of reading back through the legislative language, the task force report, and the whereas statements, which can help inform and understand legislative intent, which although I agree, are not the weight of law, there is nothing that specifically says aspirational versus attainable or speaks to that in my read. If other people would like to interpret that differently, welcome that feedback. I think what we were asked for at the end of the second meeting was what was OHA's perspective on this, and that's what I'm sharing on this slide.
Thank you.
Okay, James, Blaine, and then Brian.
Yeah, I won't repeat. I'll echo Sierra's comments on the whereas statements. I think similar to Keaton, though, and again, I appreciate your research, Sarah. It's good to understand that there is no aspirational slope, realistic framework within the law. So we have a lot of things to think about as a committee. Again, echoing just the way this slide is worded to reduce the total cost of healthcare, a negative increase. I mean, would very much fall in the aspirational. I don't think anyone in Oregon believes that cost inflation is going negative currently. I think that's
Yep.
just an important thing to reflect on. And then I get more to that point. I think for this committee to be able to set I'll use the word meaningful target that reduces the growth in healthcare costs, I think we first need to find an economic data point that's widely available that actually reflects what is the underlying cost of healthcare. Once you understand what that growth is, you can then set a target that is below that growth otherwise would have occurred. That may be completely different to GDP or wage indicators because those are measuring something completely irrelevant to healthcare. Back to the whereas statements that Sierra referred to. So I think it's important that we really think about, and I'm prepared to talk about later in the meeting, well, what is the underlying cost growth percentage of healthcare? Then we can set a target that's below. Thanks.
Thanks, James. And I think you're really speaking to some of the questions that maybe set us up for meeting four. And not to open a philosophical can of worms, but I think there's also a question here about what is an economic indicator? And is the legislative, and Keaton, you're laughing at me, but what is the intent to say, like, we're going to look at the economy and GDP and inflation and those sort of traditional, or is the cost of healthcare and premiums and employer share of healthcare also an equivalent economic indicator? I don't really want to force the group to make a decision on that. I think what we've said is probably yes, let's look at all of that data. It's on the list. I think I want to check in at the end of today about what additional data points you'd like to see. And a number of them are related to the healthcare data points specifically to James's comment. Okay, Blaine.
Thanks, Sarah. Yeah, I really appreciated today's discussion and the work you've done prior to today's meeting. It's been really helpful to remind me of how we've got here. I think when I look at that first bullet, I've forgotten who made the comment earlier to you about you were going to do some research around that. But what comes to mind specifically is, and when I look at the right side of the arrow, inflation, but more importantly, Oregon's economic growth. And I think that James kind of was alluding to this too, but what are the underlying cost drivers? I do feel like wage growth, from my lens at least, is an important part of healthcare. And I do wonder as we move these conversations forward, how that's factored into the data point that we were choosing, we might choose or guide around that. I don't know if that makes sense, but it seems like
Yep.
a significant piece is wages.
Yeah. Um, totally on the table, I think, as part of the what we're going to look at median wage growth today for Oregon. And I think if you're saying specifically we should look at healthcare wage growth, we also have some data on that. I don't have them in the slides today, but we can send that as follow-up and we can talk more about that um, in meeting four if you would like. Brian, go ahead, and then I want to maybe recap and move us forward.
Thanks, Sarah. Hey, I'll echo a lot of good work here. I tend to agree on the whereases and all that, but and actually thank you for sending this because I hadn't read it in like 6 years, so it was good to kind of refresh it. But I do think when I was reading the enabling legislation, on page two, or sorry, page three, section two, sub three, letter A, promote a predictable and sustainable rate of growth for total healthcare expenditures as measured by an economic indicator adopted by the board, such as the rate of increase in the state's economy or the personal income of residents of the state. I mean, this isn't that different from what you've said. And while sustainable isn't aspirational or attainable, in my mind, it leans more towards the attainable than aspirational if you're trying to set something that's sustainable and tied to, what we're doing here. So again, I found that helpful in the enabling legislation. So that I just want to point that out.
Yeah, thanks for that. So let me commit to something. And Kirsten, I see your hand. Hang on a second. Let me commit to something. I agree. This slide could have been worded better, both the reduction and the citations for where those statements on the left came. I will commit to updating this slide to be more specific with citations and clarify what we mean by reduce and send it back out as a follow-up. I hope that helps. Apologies for the imprecision in this. But Kirsten, please go ahead.
Sure, thank you. And appreciate those edits to this slide, Sarah. Those all sound great. I just I think there's tension here about sustainable, who we're talking about as sustainable, sustainable for who. And my recollection of that time is that the predictable was make it predictable for those who the cost growth target is applying to, so it could be known in advance, and have it sustainable, meaning that the healthcare increases that purchasers and individuals have experienced in the state historically have been absolutely unsustainable. And that was the motivating factor for the legislation. So I think we will always have this tension, and I think as we go throughout this process, there's going to be challenges in identifying the unstated. But I just wanted to say that there's another entity or group that that word applies to.
Thanks, Kirsten. I think that helpful separation of the two keywords there. Okay, let's go to the next slide because I want to again frame the discussion for today. And this is OHA's perspective. You don't have to take it. You can decide that you think as a work group that the target should be attainable for healthcare entities that are subject to it. And that is going to be your guiding principle for making this decision and, sorry, making this recommendation to OHA. I want to be really clear. OHA is not obligated to take your recommendation. So I want to be transparent with you today about this is the process and this is our perspective that we will be hearing your recommendation in. I really value everyone's engagement in this process. I think there is a lot of tension and I want to recognize that. And I expect we will continue to uncover these points of tension. But I also want to be clear, this is an advisory process. We really want to keep both the payer and provider perspective and the pressures that payers and providers are facing, and to Kirsten's point, the challenges consumers are facing, and needing to make sure that we are balancing both of those in this conversation and decision. So that said, from OHA's perspective, here's some suggested direction for the remainder of the workgroup conversations today and in meetings 4 and 5. This workgroup is the current process to revisit the economic indicators, defined broadly, and see what's happening with healthcare spending relative to the economy. There may absolutely be room to raise the target to reflect those pressures or challenges but the target should be set in line with economic indicators. This may result in an aspirational or a stretch target, and reminding everybody that there are acceptable reasons for growth that are taken into account as part of the process. The target is not an automatic pass fail with no considerations. Many of you who have gone through this process now twice have a better understanding of how that works. Um, and I would also, maybe one final point, and this is in our public reporting on the cost growth target. I don't assume that all payers and providers are in the same space. What one payer or provider might consider a stretch target may be attainable for another. We have very mixed distribution across the state, across markets, across payers and providers. Some meet the cost growth target, some do not. Some meet the cost growth target in one market, but not a second market. Some are consistent. It really varies. So I don't want to come into this conversation assuming that because one organization, or maybe all of you and the organizations you represent think that the cost growth target seems unattainable for you, that it's unattainable for everybody. And just want to acknowledge uh, the the distinctions that we've seen in cost growth performance relative to the target over the last 3 measurement cycles. Okay, Jen and then Sierra.
Sarah, can you remind us who will have the ultimate decision authority on what the number is? Is it the policy board or who will have that decision-making authority?
OHA's director has the ultimate decision-making authority.
Thank you. And then I know this has been said before in this group, and I just wanted to raise it again, that I do think those acceptable reasons for cost growth that are taken into account, that's really important in connection to the number. And so I know that there's a disconnect between that conversation and this conversation. And I just want to kind of reiterate that they are really connected, and it's hard to talk about a number without all the reasons that can be included in that number.
Okay. I will continue to say that that is out of scope for this group, but I will also acknowledge that there are a number of concerns about where are those conversations happening. If people, work group members, other members of the public have feedback on those acceptable reasons, want to continue to have discussion about that, I welcome that comment. I welcome those suggestions, and we'll figure out where those conversations are going separately from this process. Sierra?
Yeah, sorry, just to your comment about the spread and the, I guess, how different payers and providers would view a particular target. It really just reminded me, is there an update on when the validated provider data will be available? And will the
Yes.
notices of
Yes.
determinations for performance improvement plans be posted soon?
Yeah, actually, and I could have led with this actually. They were all posted and released on Friday. All of the individual payers and providers have received their determinations, and the reports are on the website. OHA has not issued the press release. We're stuck in queue to get out the door. I'm hoping the press release goes out this week, but everything is now public, and I will put the link in the chat right now.
Thank you.
Sorry, hold on, pulling the link. Okay, so the reports are on this page. And the determination letters for each individual payer and provider are on this page. Charlie.
Thank you. Sorry, I was on the other page looking at those links. Just wanted to, I guess, support especially the third bullet here, which by saying I think it almost inherently has to be at least somewhat aspirational or a stretch, because the whole point, as the previous slide said, is to actually bend the cost curve. And if we don't have a target that is not going to happen without some sort of intervention, then I guess the question might be raised of why would we have one in the first place? The whole point of it is to reduce overall spending, or the growth of overall spending. So I think just kind of inherent in that goal, the target has to be at least somewhat aspirational, or at least something that wouldn't be achieved without the intervention that the cost growth target creates.
Thanks, Charlie. Okay, before we look at data, I want to do maybe a gut check on this. And I think in meeting one, we suggested that there were a couple of key questions that maybe as a group you wanted to agree on or have as sort of principles before getting into discussion of the numbers. And I think that's where some of the attainable versus aspirational came from. That's also questions about, do we think it's more important to look at historic data or to look at projected data to understand what an appropriate target might be? Do we think it makes more sense to directly tie it to a specific indicator or to look at a bunch of different indicators and weight it? So I want to pause just for a minute here and see, do you think it would be important to have some of those conversations and try to reach agreement right now before we look at more of the data? Or do you feel like there are too many points of tension? We have an understanding of the options, and it's better to look at data and then move forward. Sierra, go ahead.
Yeah, I think that it's probably important to look at the data that has been requested. And then also, I really do think that the fact that we were just having some questions about who the ultimate decision-making authority is on this, I think that speaks to, I think, a lack of understanding about what is going to happen after this work group. And I'm just not sure that this work group is going to be able to give a fully thought out recommendation without understanding how OHA will take that.
And Sierra,
And
I would like to address that because
okay.
we shared in the first meeting what the plan was, and I believe we said it was OHA's director. I can check the record there. I apologize if that was not clear, but OHA will take the recommendation. OHA has a decision-making process where the director is the ultimate decider, and I thought we had signaled that from day one. Are there other points of lack of clarity that would be helpful today to get into?
I mean, I do think so. I think that it's more complicated as well because I think in some of the conversation about whether or not, in addition to the realistic versus aspirational conversation, I think that there's also been conversation about something that is static versus dynamic and responsive to changes in the healthcare environment as well. And I think that the true basis for that is that there are some folks who are part of this work group and who are subject to the program who are at this point wanting to have additional checkpoints with OHA, especially moving into the period of penalties and performance improvement plans. And so I think that there's still a lack of clarity about what this is going to look like moving forward. So I understand the director is going to make a decision. And then if there is a period of time where there is, again, like a need to revisit this, if there is a significant upheaval and it becomes more urgent because of the performance improvement plans and penalties, then what does that really look
And
like? I
yeah,
think that
Sierra,
we're
let me also take us back to the first meeting where we laid out one of the questions that was in scope for you as a work group was to actually make a recommendation on how often the target should be revisited. And so that is a question on the table for you to consider. We can talk about it today. We can talk about it in meeting 4, meeting 5, but there are options. Some states set their target every year. Some states have convened a work group sporadically, every 3 years, 5 years. And I think one of the parts that we would like your recommendation is, when do we do that? Some states we've set the target for 5 years, but if X happens, then Y is triggered. We could talk about that too. And that again was explicitly put in scope for this work group's recommendation.
okay. And what I'm saying is I think that that is then going to probably have some influence on the rest of the recommendations that you are looking for from this group. And it might be helpful. You were just putting the question forward of like, or is that like really what piece of this needs to come first? I think we are just kind of spinning a little bit because of some of those things. So maybe it would be helpful to bring that up sooner in the conversation with the work group.
Okay. That's helpful. Thanks, Sarah. Blaine.
Yeah, thanks, Sarah. Again, I appreciate this conversation. I think that last bullet is important. And initially, I was actually thinking we wait and look at the data. But after this more recent comments and thinking about the performance improvement plan, my perspective is attainability versus aspirational, or why is there a PIP? And the PIP's got to be there, in my opinion, because we have agreement of what we're trying to attain. So those are just some comments to reflect on, is all.
Okay. Does anyone else want to weigh in on where we go from here? Because I have another question I want to put to you all before we just jump right into data and I keep like pushing through this process because I'm hearing some comments that this process is maybe not working.
I'd like to see the data. I mean, I get all of the other pieces too, but if we're all thinking and we're talking about semantics and then the data is, wow, that is not what we were expecting, then we've lost a lot of time. I'd like to see at least some preliminary data.
Thanks, Deb. I see some thumbs up on that. Kirsten?
Yeah, I too support seeing the data, and I think it makes sense to make that decision before reviewing the timing of when that gets revisited. Because, say, for example, we set a very aspirational growth, then I think the timeline of when it revisits can be longer. If it's a much anyway.
Okay. Okay, I saw some thumbs up for that as well. So, proposal, let's take another half an hour and review some data. We're going to go pretty quickly. And then let's open it back up to a conversation about what the best way is to move forward. And I would like to agree before we hang up today on what you want to accomplish in meeting four and what the best way to get there is. And I think we might be at the point where it's time to ask people for proposals, like put something forward, put a number forward, put a timeline forward, um, put a methodology forward, or we could set up some, offline voting, and do some pulse checking. I don't want to turn this into a majority vote. I don't think that's helpful or productive, but I do think I hear the concern that we are starting to spin. I think the best way to get through that is to put some proposals forward. Um, but I also want to make space because if you all do not think this group is going to be able to get to a recommendation, and you would all prefer to say, we had 4 meetings, we reviewed all the data and discussed some issues, and we are all just going to submit public comment to OHA with our perspective, and there will not be a work group recommendation, I'm going to hold the door open on that, acknowledging the point of tension. So I don't know if anyone has a immediate reaction to that, but I do want to acknowledge it. Keaton.
I don't think we should punt before we've even tried to kick the ball. Sorry, mixed metaphor, but let's try.
Okay, you've got a heart there. Okay, let's try. Okay, let's look at some data. Um, what we're going to do is revisit a handful of the economic indicators that we looked at, well, not a handful, all of the economic indicators we looked at last time, plus a few more. And we're going to layer in the Oregon specific data, or again, as close as possible. Um, so unfortunately, we had a placeholder as well to have the state economist come and talk about some of the big picture state economy, and he was not available. And so a lot of what we're going to present today is drawn from the August economic forecast, flagging that there will be an updated state economic forecast in mid-November. That timing and our timing don't quite line up with this, but acknowledging that we can update some of the numbers and projections as soon as that new forecast is up. So, Melissa, let's go to slide 15, please. So, the economic indicators that we have prepared today, there are 5, although 4 of them we have 2 versions of. So, the first is Oregon's potential gross state product, both historic and forecasted. Second is personal income growth, historic and forecasted. Median wage growth, historic and forecasted. Inflation, as measured by CPI-U, Consumer Price Index, all urban, historic and forecasted. And then a request to look at the medical care index as a specific breakout of the consumer price index. This is the data that's in the slides for today. I want to acknowledge that there were some other requests and comments for additional data, including premium increases, Medicaid increases, Medicare increases, employer share of healthcare. And again, before we end today, I want to get your sense of how much of that we still want to see, and then we'll pull the data for meeting 4. I apologize, we were not able to pull all of the data for today. Okay, let's start with state gross domestic product. Next slide. Next slide. I'm going to skip over this because we did introduce all of these at the last meeting, but we're looking at the goods and services produced in the state. And here is the trend for the last 20 years, 2004 to 2024. The orange line is the United States. This is what we looked at in meeting 2. and the blue line is Oregon layered on top of it. So I've previously heard Oregon state economists talk about how Oregon tends to experience the national booms and busts harder. Our highs are higher and our lows are lower. And I do somewhat see that when I look at the last 20 years of trend. Um, Keaton, as our resident economist, I don't know if that is still the belief for Oregon's economy, and if you can comment on that.
Yeah, I mean, I can't speak for the state economists, but as an economist in the state, I will say that that is a story that I think is still pretty true. I can talk about why, but that's kind of maybe out of scope. But yes.
Okay. So generally we trend with national, but highs are highs and lows are lowers. Okay. The next slide breaks out the historic. So again, looking at the last 20 years and looking at the last 20 years broken up in four different ways, because there is a question about how far back do we want to look. And general assumption and the way that the group in 2020 looked at this was the more years you include in your look back period, the more you smooth out any periods of volatility. And that 20-year look back was sort of most helpful for understanding big picture growth. So in the table, you can see the look back period for 1, 5, 10, and 20 years, looking back from 2024 as the base. The middle column is the percent change in that historic gross domestic product at the national level. And the right column is the Oregon rate. So you can see if we're looking at just 1 year, 6%, and then that increases. If we go out 20 years, it smooths down to 4.7%. Next slide. Next slide. So now switching and looking at the forecast. One more slide. I pulled this graphic out of the state economist's presentation in August. And the state economist and the August forecast says that the US is now catching down to Oregon. Um, and that over the last four reported quarters, Oregon GDP growth has fallen below the US by 0.6 percentage points. There is not projected data available from the state forecast. We can go ask the state economist if there's an update, although they're busy with the November forecast and I don't know when they'd be able to get back to us. But what we did was we took this catching down information and then we overlaid it onto the projection. So next slide. If we extrapolate the national projections down to the Oregon trajectory, we can see potential projected. Those are the dotted lines on the right side of the screen. So depending on how we're averaging it out, we're looking at something below 3% or below 3.4%, depending on which trend line and how many years we're projecting. And then just as a final note on potential gross state product, PGSP is what most other states are using to tie to their cost growth target right now. Keaton.
Just one thing for people that might not look at this stuff as much as others do. We're going back and forth here in some of these slides between nominal GDP, which does not include the effects of inflation, and real GDP, which this one does. So that does include the effects of inflation. Real growth is always smaller than nominal growth. Think of it as a 3% difference as a good rule of thumb. That's all.
Okay, thank you for that. I'm so glad you're in this group. Um, are there questions or clarifications about the gross state product metrics? James.
Just one observation, and we talked about this earlier. The challenge of this one is it is negative sometimes. And so as an annual target, if we go down an annual target setting route, which I would be in favor of, it's very disconnected and becomes very, I think we're using the word aspirational. So I think it may not be the best metric, but I appreciate reviewing it.
Thanks for that. Okay, let's move to the second metric, personal income growth. So reminder, this is looking at all payments received by an individual. So wage and salary is about half. And then it also includes other income. So rental income, investment income, transfer payments. Um, so next slide. We're going to keep the same layout. The orange line is the US and the blue line is Oregon. We're looking at that same 20-year period, 2004 to 2024. And again, we trend very closely with national, um, and Oregon's real personal income, tends to decrease in line with national. Next slide. We're going to look at the same look back, the 1, 5, 10, and 20 years. The middle column is the US and the right column is the Oregon percent change. The Oregon percent change, depending on the range of historic personal income growth, ranges from 5.1 to 4.2%, depending on how many years are included in that period. Next slide. And again, we can also, nope, sorry. Here we go. Okay, so we can also look at projected. So now, same thing, we have actuals and then we have projected. These projections are taken from the Oregon Economic Forecast in August. They project personal income growth out through 2035. And we've averaged a 1, 5, and 10-year straight average of those projected rates of growth. So again, dotted lines on the right are projections for US and for Oregon, and the Oregon projected growth ranges from 4.5% in 1 year and to 4.8% in a 5-year period. Questions about personal income growth?
Sarah, it's Russ. Sorry, I can't find the raise my hand thing.
Yeah, hey Russ.
Hey, good morning or good afternoon. To me, this more aligns with the spirit of the law, that the goal is to make this affordable for Oregonians. And if affordability is a component of income, it sure seems like we've got a little better sense of what rate of change could be based on income.
Yeah, thanks for that. Other comments or questions? I know income is also something other states are using. If you remember that summary, PGSP and income or wages are sort of the top economic indicators in use. Okay, let's move into median wage. So median wage is that subset of personal income. Median wage is a little more closely tied to take-home pay, and it excludes maybe some of the very high earner dollars in the state. Next slide. Same 20-year period, same orange is US, blue is Oregon. Again, trending fairly closely. Oregon's a little higher than national, or has been in a number of the previous years. We can also look at this historic and forecasted. So next slide is historic. Same thing, 1, 5, 10, and 20 years, US in the middle, Oregon on the right. Oregon ranges from 2.9% in the 1 year historic and 3.5% in the 20-year historic. And then again, projected median wage growth coming from the economic forecast in August. Next slide. We also have this projected out to 2035. And the 1-year projection is 4.9% and the 10-year projection is 4.1%. Any questions or clarifications about the historic or projected median wage? Deb?
I have a little bit of a concern with using a general median wage growth without also looking at a subset that includes healthcare median wage numbers, because we've had significant growth in what has to be paid to staff in order to keep our clinics open. And it's more than those percentages in a lot of cases. So my clinic administrator hat is fighting with my taxpayer hat in my head, because I think all of the pieces are important, but it's trying to figure out how can we possibly do this if we can't afford to keep our doors open, I guess. So just it, and maybe that's not going to help. I don't know, but that's the first thing I thought of when I looked at this and went, yeah, our growth has been much more significant than that, just at our little clinic.
Yeah, and I think, Deb, that plays on one of the comments at the top of the meeting too about potentially wanting to see the data for healthcare workers. So I can add that to the list of potential data points for meeting 4. I also want to flag in the reports page I put in the chat earlier, On Friday, we also published a report on frontline workforce compensation based on the first year of data collection. And so you can see the growth between 22 and 23 in frontline workforce versus non-frontline workforce costs in that report. Again, we haven't really publicized or talked about that yet, but the data are out there for certainly not all providers in Oregon. It is not a representative report. It is a subset of entities in the cost growth target program, but do want to flag that that's also out there, and that might be an interesting data point for this group to look at. Yes, I will do that right now. Hold on.
I can get it, Sarah. I just pulled it up.
Oh, I got it. Thanks.
Okay.
Thanks, though.
And can you define frontline work, who all is included in the frontline workforce?
Yeah, the frontline workforce report that I just linked to has a definition that's in statute, and it is non-management folks making under $200,000 a year.
In healthcare exclusively.
In healthcare exclusively, in
Okay.
provider organizations that are subject to the cost growth target program.
And that would include all, like, doesn't need to be clinical. It could be front desk. It could be.
Yeah, the definition's on like the first page of the report if you want to see the
Okay.
specific statutory language.
Okay, perfect. Okay, thank you.
Yeah. Okay, so to Deb's point, interested in seeing what median wage growth, historic and projected, is for healthcare specifically. I don't know that projections are that specific. I might have to go do a little research, so stay tuned, but we can probably pull historic. Kirsten, I see your non-hand.
Wait, sorry, it's faster than the other hand. I'm feeling and I don't know what the right answer on this, so I just want to name this tension because I think when we talk about whether it's median wage group or a healthcare specific wage measurement, I see similar tensions there about whether we're talking about inflation broadly or medical inflation specifically. And I think some of those track with the costs of the people subject to this program, and the others are like the broader costs of people like broadly purchasing, but not only a subset is providing healthcare. I feel like we're swirling around that maybe intellectual difference of approach in both this data and in our well, how high should it be? Are we setting it so it can be met and aspirational for those provider and influenced by those who are subject to the program, or is it like based on the needs of those purchasing healthcare? And I think the reality is probably we need to find a healthy balance. One does not exist without the other. We can't, we all want a hospital to go to and a clinic to make the appointment at, and we need our healthcare. And so we can't have a program that drives it into the ground. And this was established so the cost of healthcare would not drive so many Oregonians into bankruptcy or scare them out of getting care. And so I'm hesitant about this.
Yeah. And
healthcare specific data.
Let me ask a question, and feel free to thumbs up or down on this group. Would it help address some of the tension if we specifically asked and said, if you were making a recommendation that was grounded in affordability and all the economic indicators from the consumer perspective, our recommendation would be X. And if we were making a recommendation that was grounded in the healthcare industry perspective and implications for operations, our recommendation would be Y, and put both of those forward. Would that help address the tension, or would that just be incredibly more complicated? I'm seeing a bunch of thumbs up, and Deb, I saw you shaking your head. Do you want to comment on that?
I think if you're a consumer, you don't want it to go up at all. If you're trying to keep your clinic open, there's expenses, there's things you have to do. You have to have money to do that. We're also employers. So our costs as employers are never considered with this. So while they are definitely different, I totally get that. Putting forth two, what if they pick the one that says, nope, it's not going to go up? That's not going to help anyone.
Okay. Thanks. Eve?
Thank you. I will need to go by phone, so I just wanted to make a few comments here before I'm in the car and driving. So I one observation that I would make is regardless of the indicator that we're looking at, I mean not all of them, but many of them, the annual rate of growth is more than 3%, which is ultimately what we were looking at as the potential cost growth target, kind of the default going into this. And so I think we should consider that. I have concern about going back too many years, just because ever since COVID, it's like the Mr. Toad's wild ride. Every year we have no idea what's going to happen. So I don't think that it makes sense to smooth it out over the period of 10 or 20 years until we start to see some smoothing of our economic indicators year over year, in order to do that. And I think the other thing that I would just really encourage folks in this group, I do think that the intent, and I'm a provider as well, I do think that the intent is consumer affordability of healthcare. That, to me, that's the clear legislative intent. And healthcare is very affordable when everyone goes out of business and there's no healthcare, right? So that's a reality too. And I think that we as healthcare providers need to go back to the legislature and begin talking about some of these tensions, about what was envisioned with the cost growth target compared to where we are now, and how unhelpful it is for us to all be afraid of punitive action when it would be much better for us to just collaborate and figure out how to do things like manage utilization and manage level of care and all the things that we know how to do. But we're just so fearful right now because of those hammers that it feels like are going to come down on us. But I do think that's a legislative conversation and not something that we can solve in this committee. So anyway, those are just some musings on my part, and I will listen in to the remainder of the call. But thank you for giving me the opportunity.
Thanks, Eve. Appreciate the comments and also really appreciate the acknowledgement that that may be a legislative conversation and certainly welcome if that is where the conversation goes, that's where it goes. Okay, James, and then I want to move on to our last two economic indicators.
I will hold my thoughts until after the last two. Sorry, Sarah.
Yeah, okay, thanks. Let's keep going then. Next slide. So let's look at inflation and the subset of inflation. Next slide, consumer price index. Yeah, so this is essentially the market basket. We're looking at prices for a lot of things: food, clothing, shelter, fuel, transportation, medical care, etc. We're usually looking at CPI all urban. And next slide, same graph, same colors, US in orange. And then here's the first place where we don't have Oregon specific data. The feds no longer provide state specific data, they provide regional data. And so what we have is the West region. And I double checked this today. The West region is comprised of 13 states. In my head, I thought it was fewer, but it's 13. So it's Alaska, Arizona, California, Colorado, Hawaii, Idaho, Montana, Nevada, New Mexico, Oregon, Utah, Washington, and Wyoming. So there is a wide range of experiences that are captured in that West region trend line, and I want to acknowledge that. But again, you can see we trend fairly closely to the West region trends fairly closely to the US. Next slide. Same 20-year look back, US in the middle, West region on the right. West region 1-year look back 4.3%, 20-year look back 2.8%. Again, acknowledging we're looking back from 2024. If we roll one more year into 2025, this might be a little bit higher. That data is not currently available yet. And then next slide, same. We're looking at the projected out till 2035, again for the US and the West region. And the 1-year projection is 2.7. The 10-year projection for the West region is 2.4%. So my understanding, and Keaton, again, please jump in if there's additional context you'd have on this, but my understanding is that most projections have assumed that, not assumed, there was that real spike, and that we're now looking at a flattening out over the next period of time. Do you have any context on that?
That is sort of the consensus future projection. The only flavor I would add to that is that my view is that there is more risk of it being higher than projected than risk of it being lower than projected at this moment. I would say there's pretty big error bars
Yeah.
on this, and they are not symmetric.
And there's a lot in there, and a lot of that's tariff related. Is that a fair statement?
Yeah, a lot of it's tariff related, and there are some other things that could have some substantial upward pricing pressure. Happy to talk more about that offline.
Okay, thanks. All right, let's talk about the medical care index last and then go back to our what do we do with all this information. So, um, the medical care index is one of the 8 major groups that go into the consumer price index. It has 2 main components. One is the medical care services, that's the dark blue on the graph, and that's about 82% of the weighted index. And then medical care commodities, which is the remainder of the index. So, medical care services includes professional services. That's all of your physicians. It also includes lab work and imaging, just as a footnote. It includes hospital services. It includes nursing home, adult daycare, and home health care as well. And it includes health insurance. And there's a note here that it's specifically about how the earnings are retained. So again, health insurance a lot is the health insurance collects the premiums, but then pays out on the claims. And so it's the retained earnings that's factored into this index, not the total premium, because that would be a double counting. I'm like super oversimplifying this, but that's my current working understanding. The medical care commodities, that's the light blue, it's 18% of the index. This includes drugs and equipment and supplies. So it's both prescription and over-the-counter supplies, non-prescription contraceptives, durable medical equipment of all kinds, like band-aids as well as wheelchairs or more prescription-oriented equipment. So this is a very broad index. There's a lot that's in here. Next slide. So let's look at the national trend. So the orange line is the CPIU national that we were just looking at previously. And the new purple line is the National Medical Care Index for the 20 years. So you can see that it is a little more variable than overall CPI. And then next slide, we're going to layer in the look backs. So going from left to right across this slide, same 1, 5, and 10-year look backs. CPI US, CPI West, those are the same we just looked at. We can add medical care for US city averages, that's the national, and that ranges from 0.5% in a 1-year look back all the way up to 3.1% in a 20-year look back. And then we can add West. And again, there's not state-specific data, there's West region data for the medical care index. And the West region is higher than the national. So ranging from 1.7% to 3.6% over that look back period. And as far as I'm aware, I could not find projections for the medical care index. If anyone is aware of them and wants to help me out on that, that would be great. But I could not find projections here. Okay, one more slide. These are the other requested indicators that folks flagged in public comment or emails to us. They include commercial premium rate changes, Medicaid capitation rate changes, Medicare benchmark rate changes, the Medicare physician fee schedule, personal consumption expenditures, which is another measure of similar to inflation, sort of what are we paying for goods and services, healthcare expenditures as a percentage of household income, and the percent of health insurance increase for employers. So, can we actually take the slides down and go into just like discussion? Because I want to like, where do we want to go from here? We could, we could, do you still want to see more data on those other indicators? Do you want to start making proposals about either principles or specific targets for discussion? What would be the best use of time moving forward? And Charlie, I see your hand, but James, do you want to come back to your comment now that we've gone through all the indicators?
Oh, sure. Yeah, thanks a lot. And I don't envy your task, Sarah, because no matter what number OHA ultimately picks, the majority of people won't like it based on their own lens that they look through it. So appreciate the challenge that you have in there. My only reflection on this, and I really appreciate this number, is if we go back in time, the 3.4% was set in a time with low inflation and I think more stability in the nation just in general around healthcare expenditures. And since then, two really big things happened that I think weren't contemplated when setting that target, which is inflation went crazy on everything. That's a reality. And secondly, the one that's not talked about as much is patient acuity continued and actually changed quite dramatically. And I think when we first met, I said, I think what we need to do is maybe as a group we can decide on some guiding principles, which is what needs to be captured. And I think the inputs to healthcare cost, the as well as patient acuity, because that for those of us that run primary care clinics, patient acuity is as big, if not a bigger driver of total healthcare cost than just the input costs or wage data. And I really appreciate in the numbers that you've put out, some of the wage data or the inflation factors, they do now start to recognize inflation varies and sometimes it's very high and sometimes it's very low. So I think that's a good step in the right direction. I'd be for a more flexible target based on historic movements. But can we also capture patient acuity, which unfortunately in this country and in Oregon is getting worse, and patients are requiring more care now than ever before than less. And if we set a target too low, the aspirational target is it has an impact on access at a time when the population needs more care. So I was doing a search. I'm not an actuary or an economist. CMS puts out the national healthcare expenditure per capita data that's available. It seems like that captures both of those things. But I'm not suggesting in any way that it's a self-fulfilling prophecy. Oh, it's going up at 7%, pick 7. We as a group could say, hey, we're going to pick a target that captures these two things. Maybe it's this stat. But then we set our target at 95% of that number. So we are still bending the cost curve for Oregonians, which I think is the charge of the law, but maybe in a way that we see as not aspirational, but attainable because it's based in the reality the country faces, but taking a different path for Oregon.
Yeah,
Anyway,
James,
just
no,
some comments.
I love that. And I'm laughing because I just have incredible deja vu. And so I want to recap. I want to just reflect on something and then Charlie and Keaton, hang on a second, please. So James and everyone, the reason we have 3.4% as the starting place is because Medicaid has 3.4%. And the reason Medicaid has 3.4% is in negotiations with CMS 100 years ago, Oregon said, let's look at the CMS national healthcare expenditures. They are projected to grow at 5.4%. Let's do a 2% reduction on that. 5.4% minus 2% bending the cost curve is 3.4%. So all of this conversation, back in 2011 started with those projections. And so I think, James, in some way, you just really reflected the original spirit of all of this, of bending the cost curve. And I would be happy to pull and bring back to meeting 4 the updated national healthcare expenditure projections. And if that's a place where the group wants to go, I think there's precedent for that. I will say that the CMS national healthcare expenditure projections include a lot of things that we do not include in the cost growth target. It includes public health spending. So just want to acknowledge that. It also includes some of the home health and hospice care that we don't currently reflect. So they're not a completely comparable number, but there is precedent. So, okay, Charlie, Keaton, and then Sierra.
Okay. Well, two somewhat related things, and I think somewhat related to what you were just saying. So I think having data on the percentage of household spending that is accounted for, or sorry, the percentage of household income that is spent on healthcare over those same periods of time would be helpful. In part because, I think to your other point, I think, it would be nice to see what the delta is between, over that 20-year period, how much healthcare spending increased versus how much, say, income increased. Because really that's the delta that this target is trying to close to some extent. And so we're already starting from a point where healthcare spending and healthcare costs are way higher than they should be. And so I think we need to account for that when we're setting the next round of targets to not just, keep the already way too high spending no higher accounting for inflation than it currently is, but actually try to get it below that a little bit. And so I see, like the 4.5% annual increase in wages, we should be thinking about it, like you were saying, something lower than that amount, to make up for the fact that for too many people, the current costs are already way too high.
Thanks, Charlie. Keaton?
Yeah, thanks for that additional data. It's I have two things I want to say, and then maybe an offer potentially at the end of that. One is that picking up on what James said about the acuity issue, this cost number, this overall state level spending number is really like price of healthcare times quantity of healthcare. And so you can blow through the cost target either by prices increasing or by quantities increasing. And, I think many of the people here, I don't want to make a presumption, but I think when I see the legislative stuff, I'll maybe make this presumption. I think the legislature has a different normative view of one of those numbers versus the other number, right? I think the legislature is more skeptical of prices changing than they are of quantities changing. That's the way that I read all of those whereas clauses, et cetera, et cetera. So I think that is part of the sticky wicket here is that we are trying to do one number to kind of get at two things. I mean, among the many sticky wickets. And one of the things that bounces around in my mind at the national level is the conversation about I'll put it somewhat euphemistically, measuring acuity. And to make it more concrete, I know that CMS has had to implement an updated risk adjustment model because of some behaviors happening in the Medicare Advantage space. In fact, I have some research in progress on this issue, and happy to talk more about that offline. Um, in any case, I sort of like the idea of thinking about that. If there's a way that we can think about acuity that gets at that core issue that avoids some of the problems that have been seen at the national level, I'm sort of broadly in favor of thinking about that. The second thing I want to say is that I am a little skeptical of taking really seriously internal industry measures of cost growth to decide what the cost growth target should be for the industry. If anyone wanted to say the foxes are guarding the hen house, like that's how you say it, right? Or that's the thing that would happen to cause that critique to come out. Obviously, a lot of these measures, like median wage growth. Well, healthcare workers are part of the subject population that median wage is calculated from. So the healthcare industry is part of that, right? The CPI, healthcare costs are incorporated into that at some level. Of course, there's going to be some circularity, or what we call endogeneity. There's going to be some circularity there. But I'm worried about saying, you know, we should we should increase costs 5% next year because we increased costs 5% last year, which is sort of what that's my fear about what we would eventually be doing if we incorporated that metric at too high of a weight. That isn't to say that measures of things that people like providers and organizations don't have control over aren't important. That's not what I'm trying to say. I'm just trying to say that if we weight that too high, we have kind of a problem. Um, the last thing I'll say is that I hear you saying, Sarah, that like we need to get to like proposals. I like maybe it's ridiculous for me to offer this, but like I'm happy to put forward a number for meeting four, and see what happens, see how people feel about it. Maybe that's a terrible idea. No one wants to know what my number or my thought is, but at least is like here's a starting point for conversation, and maybe that would inspire other people to come with numbers as well. A thought. Okay, I'll stop talking.
No, thanks for that offer, Keaton. And I think given where we are, I'm going to ask people to do some homework between meeting 3 and 4 and send me some thoughts. And I'm happy to talk about like I can anonymize them if you would like me to. I can synthesize it. But I am going to ask people for proposals over email between meetings so that we have some concrete starting points. It is so much easier to react to a straw proposal for a discussion than this sort of theoretical tension space that we've been swimming in for the last couple of hours together. And I will also acknowledge that the current starting place straw proposal is the 3.0%. And I think we heard loud and clear from this group that that was a non-starter for you all at the first meeting. Or maybe not you all, but many of you at the first meeting. So happy to talk about that before we wrap up about what that ask for you all is. But Sierra, please.
Yeah, thank you. I just think that there have been requests from quite a few members of the work group since the first meeting to at least have a conversation about some healthcare industry specific data. And so I think my opinion would be to at least make that available before collecting recommendations.
Okay. Hear that. Okay. Other thoughts. And I want to pause for a second because I know there are a number of people on the line who have not yet chimed into this conversation, and I want to make space for that. Does anyone who has not yet engaged today have comments, questions, suggestions?
Yeah, this is Cliff. Just really quick, just I'm listening to this whole thing, and I get what we're trying to do, making this affordable for the consumer. I think part of the concern is like one, the 3.4 or the three, how the inception of that. I mean, that was very aspirational, right? And when you say reduce 2%, you mean 2 percentage points, because
Yes.
from 5.4 to 3.4 is like what, 37
Yes.
percentage? you know so that is very significant for any one in healthcare to absorb, or anyone in any industry to absorb. You ask any industry, hey, can you take a 37% reduction 1 year? I, I think that'll be very hard regardless of what industry you're in. um and I think the biggest concern too is a lot of the cost growth is driven by factors that are outside of the hospital control. It drives the cost of care, but we don't have control of the cost of care, right? So when this becomes when we have a punitive aspects of accountability over something we have no control, I think that that does warrant some of this tension and concern, right? I do agree with the previous comments, of acuity. I think that's a major factor. Yes, there is rate times usage, which equals the cost, right? But the acuity really drives that usage. And instead of just a hardcore, hey, here's a rate. What are elements that the state can consider assisting or supporting the healthcare system, then that we can then become more comfortable landing in a realistic target. So yeah.
Thanks, Cliff.
Yeah, but thank you.
Tara, did I see you come on to speak?
Yeah, I came on camera, so thank you for watching, Sarah. I was trying to be quiet today because we did submit a comment letter that kind of responds to a lot of the questions you raised today, but I'll kind of echo what we heard. I think it was the Hospital Association saying we'd like to see some of that data on kind of the healthcare expenses and what those inflation rates look like, cost of care, the cost of providing coverage for folks. And then I also wanted to just remind our group, you asked us a couple other questions. One of them was, are we looking to kind of make a rate recommendation that's consistent over a number of years and how many? Or are we looking to kind of create a formula that OHA would apply? So I think we should remain cognizant of that question. And well, I guess those were my only two. Yeah, that's what I have. Thank you.
Thanks, Tara. Others? Okay. I'm not seeing anybody jump, so let me make some proposals and maybe reflect what I've heard. clear interest in seeing additional data on some of the health industry specific measures. We will compile that and push that out to you as fast as possible. I will do what I can. Um, Aim for the end of the week. Might not be till early next week, so apologize for that, but we will get that out. I will ask that you take a look over that before the fourth meeting. Second, I've heard a number of you reference back to whether or not we should have some guiding principles. And I think this is maybe the first homework ask. And I think if people would like to propose some principles, that might be a nice place to start the conversation. And I think those principles could be we're focusing more on industry. Maybe it's like a weighting. Maybe it is we're focusing more on the consumer perspective and maintaining that. Maybe it is that the target should be revisited annually. Maybe it's that there should be a formula that OHA applies. I think it would be helpful to get a sense from you all what you would propose, and it would be helpful to see how much agreement there already is on some of those points. And I think the principles conversation can potentially happen. I'd love disagreement, but could potentially happen without necessarily seeing all of the specific healthcare indicators. We'll get those out as soon as we can, but I think those conversations can happen in parallel. Any reactions to that proposal slash request for you all?
Do you still want us to make a proposal over email on the percentage or just guiding principles?
Well, that was my next question. So I think if anyone feels ready and comfortable to make a proposal, and I think somebody, Koff, Keaton, maybe is, like, I think I welcome that as well. I think we can use that to help set the conversation and even just to see the range and what it's based on and where we're landing. That might be helpful for framing. If people want to hold off on that, and I did hear several people who do not feel comfortable recommending a number, a percentage until they see some more of the data, that's fine. This will not be the only opportunity, but if you feel ready, or want to propose something that's in the middle, it's not quite a guiding principle, it's not quite a number, but maybe it's a formula. Like, I think we should use these two indicators and they should be blended in this way. Um, this would be a really great time to have that proposal. So I think what I'm asking is if you have feedback, I really want it now. I really want it between these two meetings and whatever level you're comfortable. And if you can please tell me if you want it to be posted publicly or if you want it to stay internal and I'll sort of synthesize and anonymize it. That would be helpful. I do want to respect if you have if you aren't comfortable sharing something publicly, I'll make space for that. How does that sound for everybody? Is that like too vague of an assignment, or do you all feel like you have some thoughts and can get back to us? Okay. Yeah. Thank you. Yeah, and again, there's so much tension here. I appreciate the regrouping on some of the intent and everyone who did look back at the legislative intent. It's always tricky to go back and try to remember or try to understand what people were talking about 5, 10 years ago. And acknowledging that we are looking to set a target. I would like a recommendation from this group. I think my earlier question of, do you think the group should still keep meeting and do you think we can get to a recommendation? I feel a little bit more confident about that than I did 45 minutes ago. Does anybody have additional comments there on continuing to move the conversation forward and come to a recommendation by the end of meeting 5?
I have a question.
Okay.
I totally understand that we're only here to talk about the percentage or what our recommendation is and stuff. But in my mind, it's tied to how some of the program works itself. And I know we're not talking about that, and that's cool. So is there another group working on the program itself? Or is there a place we can submit comments that, in a backwards way will actually help this? But I guess I'm sorry I'm fumbling with that, but
yeah,
I
nope,
feel
I know
like,
what you're asking. Yep.
Yeah.
So I think we've said this in a couple of places and acknowledging that maybe it hasn't been as clear as it could have been. We do not currently have a rules process open, um, and no immediate plans to open the rules. I think if we're hearing a lot of comments that maybe we need to do that and here are the suggested changes, I'd like to know that. I think a lot of what I've heard so far, like just in general in the last couple months, is not actually a regulatory level change. It's about program operations. And I think we've been handling some of those conversations through our monthly technical advisory group. If that's not the space, if you're not feeling like you're able to surface that, I would really love a comment. Feel free to email me directly or into the program inbox. And I encourage any of you, because I know that there are concerns, and if you're feeling like you're not sure where they should go, please tell us. Please tell us what you're thinking. If you have concrete changes, I'd like to hear them proposed because I think uh, there's a little bit of frustration. You are all frustrated with me, fair. With the we don't know where to go, we don't know what to say, but it's hard to hear some of that without it being a like, it's this thing that we don't like. This is not working, and here's what, as opposed to just we don't like the cost growth target because we don't want to be accountable to the cost growth target. So I'm paraphrasing, and none of you have actually said that to me to my face, and I'm not trying to accuse you of that. And if there are specifics, it would be really helpful to hear what the specifics are that you think are not working and what you would like addressed. And then OHA can figure out where that conversation should happen, whether it's a rack or something else. Okay, Daniel, then Paige.
Thanks, Sarah. I would say I don't think anyone's frustrated with you. I think people are frustrated with the program, right? And everyone acknowledges like you're doing the best you can with your job, right?
Oh,
And
sure. It's not
it's okay.
personal.
So it's not personal. I think that we can get to a recommendation as a group. I think we should keep moving in that direction. I think once people start advancing proposals that that we will see how principles are
Range.
pressure tested a little bit, and those will form and harden. And I think we can reach at least a couple narrow, a narrow list of recommendations, if not a final recommendation. And we ought to keep moving in that direction and try to execute that. This is all art, right? This is sort of loosely based on science, but it's art, right? Like however we get there and get to this recommendation and the way that it was said the first time too also, right? Like so there's no right answer, but that doesn't mean we can't come up with something that's constructive.
Daniel, I really appreciate you saying that because I've spent the last 5 years defending to other states when they're like, what do you mean Oregon's target is based on? What do you mean it's not directly tied to an economic indicator? What do you mean you triangulated it? And so really appreciate that acknowledgement that this is an art. Okay, Paige.
Yeah, just to speak to your point about not having any clear or specifics about what is so challenging about the program. I think the years that it was implemented have been incredibly unpredictable.
Yeah.
And we are being held accountable for cost growth when we saw such a significant dip in utilization of care at the beginning of COVID, which is basically the first year that we were compared against. I think that a lot of these groups, I'm sure, are involved in some way or another in value-based care programs through payers, and are committed to this work. But from I'm multi-specialty, my practices, but a lot of this work falls on primary care. That there are a lot of things that are out of our control in terms of rebound utilization and pharmacy costs and other things that we're trying to do a lot of work to manage the total cost of care, but we're facing the same cost pressures as organizations as everyone else in the state is. And our expenses are going up substantially. So I think the challenge is that that there is a lot that's out of our control. And I know that you're going to probably tell me that's out of scope for this group, but I feel like I am happy to have more conversations with you about specifics because I think all of us have been pretty vocal in our one-on-one meetings with you guys about what the specifics are and how hard this is to navigate when nothing in our world has been predictable in the last 5+ years. So I think it's not that we just don't like the cost growth target. It's that we have not had any predictability in how we're performing, and we're also defending costs that occurred 2-3 years ago. and we have no control over. And I think the threat of financial penalties is really challenging because how are you supposed to make an impact on something that happened 2 years ago that you don't have any visibility into until 2 years after it happened?
And Paige, I want to bring that last point back about the timeline to this process and to this target, because when the target was initially set in 2020, part of the reason to set it for so long was so that everyone knew what they were working towards,
Right.
because there was always going to be this measurement lag. And there was a lot of conversation back then about we don't negotiate our contracts every year. We need to be able to plan ahead to put this into place so that we can meet the target, so that when we are looking back, we had that opportunity. And so as this group now is thinking about setting the target moving forward, I really ask you to remember that point, because the cost growth target will always have a lag in collecting the data and revisiting it. But I think it has been known in Oregon for a long time that there is a cost growth target. And so wanting to send messages and saying, here's the new cost growth target, work towards it so that we are reducing that. Like, we had no control over the cost. We didn't know what we were working towards in that time period. And now you're asking us to justify it. I'm really hoping that, like, as we continue, that reduces. But I hear you on the timing.
Yeah, I would say yes to that. And I think that um, none of us could have, well, I mean, we predicted, but it's still kind of ongoing, the rebound utilization based on people deferring care. We're
Yeah.
seeing cost on cancer drugs increase substantially. I mean, there's obvious ramifications to the health of our populations as a result of deferring care during COVID, and we're continuing to see those trends. And so, yeah, I mean, I think everybody is on board and understands that this is here, and we're aware that we're being held accountable, but you're still acting on data that's really old, that is not very actionable. And I don't feel like, again, this is past this, but just to put this out there, I don't feel like the OHA is giving us a lot of guidance on how we improve. We're kind of being told you're not meeting it and there are these financial penalties, and we're all doing the best we can with way fewer staff than we need to be successful in all of this. I would say probably most of us on this call who are in healthcare are experiencing that. And so it does feel kind of like you're doing it wrong, but we're not being given any tools or any, we don't have any control over the drug prices. We don't have control over, a number of factors in this, and we're all doing the best that we can. And so I think that's the frustration. And also, I don't know if there's an attitude that healthcare is swimming in money right now, and we're not.
And
We're all
Paige,
really-
I really appreciate that perspective. And I do think that some of this is a conversation that we can take offline. And I want to acknowledge just a lot of the concern. And I want to maybe just add one point, which I think is maybe turning into part of the request for all of you, that, if there are specific suggestions. There was an explicit conversation back in the day, 2018, 2019, that payers and providers did not want the state to tell them how to do this, that they did not want the recommendation of do X to meet the cost growth target, because everyone was unique and needed flexibility. And I said this yesterday, folks heard me at State of Reform say this, like, there is a change. And the last couple of years, I think we're really at a point where it's like, yeah, we do want to know, what are the tools, what are the solutions. We're ready for that convened work group. We're ready for that collaborative effort. We're ready for that table. And if that's true, if that's where we are as a state now, that's great. Like, let's do that. Let's start working on those conversations and those collaborations. And would like to acknowledge that there was like a very clear, like, don't tell us what to do at the beginning. And if we're now at a sea change and need to revisit that, I really welcome that feedback. So I want to stop. I see Sierra and James, you have your hands up. I'm going to end us because we're at 2:29. I want to make an explicit call. Payers, we didn't hear a lot from you on the call today. I want to make sure that you send us your thoughts as well. This has been a very provider-heavy conversation. So please feel free to send your comments and your letters. Everyone feel like you are clear on next steps. You are going to email feedback to me, clarifying whether or not you want it to be public or not, or anonymized or not, with your level of suggestion, whether that's guiding principles, formula, methodology, specific number, or any combination of the above. Separately, if you have specific suggestions about program improvement, which are out of scope for this group, feel free to send those, and I will start working on that conversation with you as well. Okay, closing thoughts? Everybody clear? Okay, we will talk again at meeting 4, which is going to be really soon. I will do my best to get that additional healthcare data out to you as soon as possible. Thanks everyone for your time, and we'll talk to you soon.